one, positioning your patient. And make sure that you don't, actually, I'm gonna grab a stool. And if you wouldn't mind taking off your watch for me. That way that's out of the way. Alrighty, so we want Maddie to be very well supported, and we want her hand to be able to hang off the edge. So if you wouldn't mind, let's go ahead and scoot your setup forward just a bit. There we go, and then go ahead and bring your arm down onto the table, and I'm gonna raise it up just a little bit. There we go. So she doesn't have to have her arm perfectly squeezed to her side like we wanted it more adducted for pronation supination. As long as we're being mindful to stabilize the form, if we do see her cheat a little bit, we're probably okay there. All right, now, goniometer, dealer's choice. I like the flat one just because then it's not gonna hit the table as much, but if you wanted to use this one, you absolutely could. No penalty for choosing that one. I'll have both available. Okay, so in our textbook, there's some wording that I don't necessarily care for, and I'm just going to throw it out there because on a quiz or exam, I'm going to use the wording that is in the textbook. Don't hate me, hate the textbook. What the wording says is after it describes the patient position, it says you're going to put the goniometer up against the lateral side of the wrist over triquetrum. You tell me, what's the lateral side of the wrist? In this position, no, in this position. Anatomically speaking, is that the lateral side of the wrist? No. But because we have the forearm pronated, technically, just looking at this picture alone and no other context given, that's what they mean, is the lateral side of the wrist in this position. Anatomically speaking, this is still the medial side of the wrist. It doesn't matter that we moved out of anatomical position. But we are going to use triquetrum to ballpark where the axis of rotation is going through capitate. So bear with me when I say lateral side of the wrist over triquetrum. This is what I mean, and I'm using that language because it's how it's phrased in the textbook, not because I love the language. We're all okay with that? Cool, excellent. Alrighty, so I'm just gonna have Maddie relax here, sitting up nice and tall, both feet flat on the floor. And I'm gonna first start by palpating for the styloid process of the, is this the radius or the ulna over here? Ulna, yep. Teeny tiny ulna. Here is the joint line for the wrist, that nice little space, kind of squishy there. That's where her articular disc is. And then coming right down off of that, now I'm on triquetrum. Here's pisiform on the palmar side, and here's triquetrum on the lateral side. So I'm gonna approximate through capitate this way by using triquetrum for my fulcrum. Does that make sense? So I'm going to carefully not destroy the plug and line up the fulcrum with triquetrum. And then I'm going to have the stationary arm coming up along the lateral aspect, or medial aspect of her ulna, all the way up towards, I think the textbook uses the lateral epicondyle as the landmark there. Now, the moving arm is going to follow the lateral edge of her fifth metacarpal, not her phalanges, because she can extend that pinky back, but that doesn't really give me adequate motion for the wrist. So we're following just the lateral edge of the fifth metacarpal. And then I'm cueing Maddie, go ahead and lift your whole hand up as high as you can. There we go. Oh, fantastic, wonderful. And she has 80 degrees of wrist extension, which is actually a little bit more than normal. Now let's say Maddie did that motion and she did not have a lot of wrist extension. I could then ask her, go ahead and relax your fingers and go ahead and bend back. There we go. So remember those long finger flexors, if I ask her to lift her whole hand up, fingertips up towards the sky, I'm getting a stretch through the entire anterior aspect of the hand, fingers, and forearm. So if your patient's having a hard time with that, could be because of passive insufficiency in those long finger flexors. So because we're really trying to isolate the wrist and get as much range of motion out of the wrist, you can cue your patient. Go ahead and relax your fingers, let them curl up, that's just fine. I want you to bend back at the wrist, try and bring the back of your hand up and back towards your forearm as best as you can, and then you can measure that way. And we can stay here and do the exact same position for wrist flexion. And again, just cueing the patient to keep their fingers relaxed and bring the palm in toward the table, and then same exact landmarks apply. We're okay with that? Does that make sense? Perfect. So that's for sagittal plane movement. Make sure the hand is off the table and has plenty of ability to move. Now for radial and ulnar deviation, we're actually going to have Maddie scoot back a little bit and bring her arm fully on the table so that her hand is supported, because now we're going to do frontal plane measurements. And what we're going to do now is we can go directly over capitate, which again is very easy to find. We're just going to follow her third metacarpal in. There's capitate. If you want to mark it with a pen on your partner, you absolutely can. The stationary arm is going to go right up the center of the forearm, and this one is definitely up to the lateral epicondyle, because that's a nice straight line there. And the moving arm is not going to follow the fingertip. It's going to follow the third metacarpal, because as we're going to learn in a couple weeks when we get to the hand, this can AB and AD duct. So that can give us a false number if we follow all the way down. So we're going to follow the knuckle, her little dimple there on her hand. So again, utilizing those landmarks, I can then ask Maddie to go ahead and bend at her wrist toward her thumb side. And she has about 15 degrees, which is normal, and then towards the pinky side, all the way for me. There you go. Oh yeah, she's got a lot there, and that is actually more like 40 degrees. So she's a little hypermobile into ulnar deviation. But again, the idea is she's always going to have more ulnar deviation than radial deviation because of the size and shape of the styloid processes of the ulna and radius. Does that make sense? Cool. So range of motion activities, we're just going to stay in the exact same position. So Maddie, go ahead and scoot forward for me a bit again and let that hand hang off the edge. So if I'm testing for her wrist extensors, I'm going to palpate any of the wrist extensor muscles that I want. But again, make sure you're palpating over the right muscle. So if I find the lateral epicondyle and come over as far as I can on the radius, that's extensor carpi radialis longus. Brevis is next door, and extensor carpi ulnaris is on the medial side. So I'm going to be paying attention whether you're palpating on the far radial side or closer to you on the ulnar side, and which muscle you tell me. If you're over here over the ulna and you say, oh yeah, I'm testing for extensor carpi radialis, I'm going to be like, no you're not, try again. So just be mindful about where you're palpating for, and then I'll palpate that muscle. Go ahead and lift your hand up. Perfect, I felt it working, wonderful. Now I'm going to have you lift up just part way to about right there. Hold that position. I'm going to push down on the back of your hand to see how strong you are. Don't let me move you. Are you ready? Here we go. Hold that position for me. And 3, 2, 1. And I'm pushing in the direction of wrist flexion. And I'll give her a 5. That was pretty strong. To do the flexors, I will have her turn over this time so that I can palpate the muscles and apply pressure across her palm. So again, what that would look like, I would palpate for the medial epicondyle of the humor. There's the common flexor tendon. If I stay close to the ulna side, that's flexor carpi ulnaris. If I'm in the middle, that's palmaris longus. And if I'm on the radial side, that's flexor carpi radialis. Perfect. Go ahead and lift up your hand for me. There we go. And relax. And actually, let's bring you this way. It's a little more comfortable. There we go. And one more time, go ahead and lift your hand up a little bit. I'm going to have you hold that position. Don't let me push down on your hand. You ready? Here we go. 1, 2, 3. So I'm stabilizing the forearm, making sure it doesn't lift up off the table, and then I'm applying force in the direction of wrist extension. Cool beans? All right, for ulnar and radial deviation, go ahead and scoot yourself back. If you really want to, you can do up against gravity. I'm kind of a lazy therapist, and I just do it in the same position that I do the other two. So again, asking her to ulnarly deviate or radially deviate, and then applying resistance either in the direction of radial deviation or ulnar deviation. Easy peasy, right? Yeah, pretty straightforward.